Okay, this is PTAS 207, modalities 2, and this is a continuation of the lower extremity diagnoses, starting with the hip and then going into the ankle foot. Okay, so the beginning of these notes is the handout that goes for patient education for a total hip replacement, and then notes for the ankle and foot. What I have right now that's showing on my screen is a WebMD animation. So remember, a lot of these things are animations related to the industrial companies selling the components that go with these procedures. So this is a quick video of the hip replacement, again, just to get a basic understanding of the process and the pieces involved in this procedure, and then to discuss the patient education component next. So this is just about a minute long.
During a total hip replacement, your surgeon will replace your hip joint with a prosthetic hip. The hip joint includes the ball-shaped head of the femur, which fits into the socket or acetabulum of the pelvis. Smooth articular cartilage covers the bony surfaces, cushioning the hip joint and allowing the parts to move easily. The most common cause of hip disability is osteoarthritis, a chronic disease in which articular cartilage wears away, resulting in severe hip pain and stiffness. When pain medication and other treatments are no longer effective, your surgeon will perform a total hip replacement. During the procedure, your surgeon will remove the damaged cartilage and bone and reshape the bony surfaces.
Okay, so taking a look at this acetabulum, what we see is that lighter blue color that they represented as articular cartilage, and that's actually what's left of the cartilage. And so when we talk about bone on bone, we talk about the two bony components starting to approximate to each other and therefore wear on each other, and they're actually scraping off that cartilage. So you actually see that red inflammatory type of process. And then we just see basic bone spurs in this little area here, and some wear and tear across around the edges of the joint. So it's also wearing on the labrum as well.
To fit the prosthesis or artificial joint. A cemented artificial hip joint includes a socket with a smooth liner and a stem topped with a ball that replaces the femoral head. Your surgeon will cement these prosthetic components into place.
And again, the cementing process is depending upon the patient. So cemented is generally used for patients who cannot grow bone for themselves, maybe somebody who is more osteoporotic or has osteopenia, somebody who is older potentially, and any other condition that would affect them growing the bone between their own bone cavity and into the interface or the surface of the prosthesis. People who would not get this cemented would be people who are younger, have good bone growth, or potentially may have an allergy reaction to that glue.
Then your surgeon will fit the new femoral head into the new socket. Before closing the incision, your surgeon will check the new joint's range of motion to ensure it functions properly.
Now keep in mind with that, patients who have had arthritis conditions as such tend to have hips that are tight into, meaning that they're more positioned in these positions of introtation, adduction, and flexion. So they have lost over time extension, abduction, and external rotation. So while the surgeon will check the mobility of the joint from the prosthetic point of view, when they're doing that, they are, under anesthesia, stretching out those other tissues like ligaments and muscles and tendons in order to gain the range of motion that they need to see occurs with that joint, the new joint. So there's a little bit of wear and tear happening at those other muscles that have become tight over time, and so that adds to the discomfort for the patient as well.
Over 90% of patients experience dramatic pain relief and improved hip function with a new joint that will last about 15 to 20 years.
Okay, so let's just take a moment. Let's go. Not that one yet. Where is he? There we go. Just want to be sure. EDC Web 29966. Okay, so we're definitely on the right page here. Okay, so here's from your notes, and this is one of the components that is required part of this class, is understanding all the more functional and daily routine activities related to patient care, and there are definitely very specific ones for a total hip replacement. And remember that there's two different approaches for a posterior aspect to the surgery or anterior aspect to the surgery, and that changes the precautions that are provided. Now, in areas where scientifically the hospitals are university associated, so they're educational hospitals or research hospitals, and you might be in like the hub of a main city hospital system, you're going to see the more advanced surgeries. So you're going to see the more advanced surgeries being an anterior approach to a hip replacement. You're going to see smaller surgical sites because the components aren't just that acetabular cup and then the plastic that goes inside that and that very long femoral stem with a head, that they actually have the femoral component is actually in 3 pieces, and so with that one gigantic piece, there's a much larger surgical cut in order to get that into the body. Now there's much more advanced pieces where they actually take the little pieces and stick them in the body, and they build that component while the person's in there, while the surgeon's inside the body. Okay, so what's the benefit to those things? Again, there's less cut to other soft tissue. There's less disruption of, the joint capsule, other muscles. There's less precautionary things that are necessary for the person to follow functionally. So those are all the good advantages of having those smaller pieces that are built together and then once they're in the body, they're put together and put in place. The disadvantages, anytime you have multiple pieces, we have additional places where that structure could fail. Okay, so being the fact that we're in Northwest Indiana, the fact that the anterior approach is, I don't know, at least 10 years old, just not as common, the majority of the patients that you're going to interact with will be a posterior lateral approach. So this particular document was meant for patients who have a posterior lateral approach hip replacement. So the precautions that are in here, the functional precautions, do not relate to the person who has an anterior approach. They are different. Okay, so this technically was a document that one of the students actually brought to the program because it was a document that was actually given out at the facility. So these are things that they give to the patients in order for them to understand better what it is that they're going to get involved with this replacement. Okay, so here they're just talking about, okay, here's you with your new hip. If you notice up here, there's the trapeze that's hanging above the bed for someone who needs to get assistance for getting out of bed. This is, again, very common for people who do not have lower extremity use. So this is more common for patients who have spinal cord injury or someone who has an amputation, because as they try to sit upright, they don't have the weight of their lower extremities anymore to stay down and use that as a counterforce. So oftentimes they use the trapeze instead. For patients with the hip replacement, we're going to see things like a lower extremity lift aid that we do actually have at the clinic. It's, at the college, and it's like a little hook that hooks into the shoelace, and it's on a long bar. So you hold the bar, hook the shoelace with the bar, and then use that to help lift up the lower extremity. Straight leg raises are not allowed at the beginning of maximal protective phase. So they're not allowed to just lift up their lower extremity, nor can they usually, but because that would actually cause force right at the point where the femoral stem goes into the shaft of the femur, and that could potentially cause fracture and movement in that implant shaft interface, and then it would actually make that implant mobile. Okay, so let's get rid of that. Maybe not. No, I always want to do that. Okay, so we're going to move down. Okay, so some of the things that they talk about for patients is, you know, after the surgery, will they still have any pain? Well, not pain from the joint, because the joint is gone, and that's where the majority of their pain was coming from, but they will have some pain from the soft tissue that was invaded in order to get to that hip joint. Again, they might have some pain when they actually do their exercises, because they, you know, again, that surgeon was doing some pretty aggressive range of motion in order to check that range of motion in the new hip joint. So you might get a little microscopic tears in those muscles and tendons that were necessary, but in a sense actually help to open up that tissue for after surgery. So it has some benefits as well. So anyway, they're just kind of talking to you about what a patient would know. Okay. Okay. So they're talking. They give a little bit of a demonstration of what's going on, and they're showing you the idea of the healthy hip. Now, this has been scanned a variety of times, so it's not the best picture. So you're probably in-hand pictures is better than on the screen. And then also you can go online and look at some of these pictures as well. We already saw the picture of the problem hip inside that video, and then what the replacement looks like. Okay. You do see a little bit of a deviation if you look at the gluteus medius muscle, which is running directly superior from the greater trochanter in each of the pictures, and you do see that it's a little bit less defined in the third picture because of the fact that it is actually in the posterior lateral approach, it is actually cut into and separated in order to put the prosthesis in. And that lack of that gluteus medius is one of the reasons we have to watch that those precautions, because that lateral support soft tissue-wise on that side of the hip is missing now. Okay? So things that you're not allowed to do then afterwards are motions that cause the hip joint to move posterior and lateral, because we cut through all of those things to get the implant into the body. So any arthrokinematic motion that would cause the head to go posterior and or lateral would be avoided. Okay? So if we think about this, we have the, let's say from standing, person standing, there's the pelvis, and there's the lower extremity, here's the knee, okay, there's a head. If we go to hip flexion to 90 degrees, we have an anterior and superior arc of motion, and so the opposite would be occurring at the hip joint because the head is moving. So let's back up. We're going to move an open kinetic chain, hip flexion, from anatomical position to 90 degrees of hip flexion, in which case we have an anterior superior arc of the distal tibia. Okay, so that's the osteokinematic directions. Then the head is convex on the humeral head, which is the mobile bone, and since it's convex, the concave convex rule says the arthrokinematics would be in the opposite direction. So if we're doing an anterior superior, we're going to get a posterior inferior motion. Okay. Now when we actually go further up into that superior position, okay, past that 90 degrees, we have really forced that head in a, so now we're going superior, posterior, we're having a inferior and an inferior and anterior position, but we've made that joint capsule extremely taut. in which case that is really truly forcing that head in that back, down, and anterior. So we went posterior, inferior, anterior in an arc motion for the head, and that's pushing directly on the structures that were cut. Okay, so again, the rule is that they are not allowed to flex the hip more than 90 degrees. Now, functionally, what that means is they are not allowed to do deep squats, not allowed to deep sit. So things like chairs and toilets and squatting to pick something off the floor, all of those things are limited for them. Okay, so we need to do some adaptations, and oftentimes what we have is reachers that the patient has, or sock aids to help them put their sock on so they don't have to flex their hip that far. Okay, now again, this is the posterior lateral approach. An anterior approach is going to avoid the extension process. Okay, let's see. We talk about a variety of different things after the surgery, and in this case, we're talking about the exercises. And so you'll see very common exercises that were provided in the original lecture for the lower extremity diagnoses. We're doing calf muscles. Now, it says bend your feet toward you, use your ankles to flex your feet, and away from you to point your feet. Now, again, remember, this is about the purpose of preventing or decreasing the chance of DVTs, so it's important that the plantar flexors are actually the focus of this exercise, which means then they have to be pushing down, not just dropping their foot down. Because if I pull my foot up into dorsiflexion, that would be a concentric contraction, and if I just let my foot go down with gravity, that's an eccentric contraction. So it's going downward with gravity, easing into plantar flexion. So if it's an eccentric contraction, it needs an opposite muscle of the action. The action would have been plantar flexion, and it would have been an eccentric of dorsiflexors. That's not going to do what we needed to do to squeeze on those deep vessels within the calf muscles. So they have to push down and tighten up their calf muscles in order to squeeze that gastroc. So this is really important that this be taught properly. This isn't just an ankle dorsiflexion activity, okay? It needs to be a concentric dorsiflexor and a concentric plantar flexor, okay? Okay, then the other exercises that you generally see in the exercises that we've already talked about is tightening up the quads, and that's doing the quad sets. Remember, a set exercise is an isometric exercise, and they're suggesting that the patient should do those quad sets in order to start retraining and understanding how to use their quads for when they start doing functional activities. Glute sets, which is what they're doing with their buttock squeezes. And then doing some passive range of motion using the towel to help move that hip into flexion and then lowering it back into extension. Most people do pretty decently with the hip replacements. They're a little more complicated because of the surgical intervention and the blood supply issue in order to desanguinate the lower extremity because the hip joint is harder to access and requires some additional soft tissue involvement in the surgery. But range of motion wise, they do pretty decently with this activity, with this surgery. Knees, however, tend to have more limitations in range of motion gains. Okay, so you can see this patient is walking along with a walker. It would be a pickup walker at first in order to be to allow the weight-bearing status, because remember, depending on the cemented or non-cemented, our patients are going to start either way in a toe-touch weight-bearing situation, and then they're going to progress according to cemented or non-cemented with their weight-bearing. And cemented will actually go faster to be able to start putting that foot down. Okay, so you'll see you might be traversing with them with an IV still in place if you're actually working with them in acute care. It's about 3 days for a knee replacement in the hospital and about 5 days at most for a hip replacement. But again, the motivation is to not have the the patient there for very long. Okay. Many patients will go home and have home therapy, or they'll go into a subacute rehab facility and get daily care for so many days before they go home. Following the restrictions, again, this is for the posterior lateral approach. We talked about the fact that we're having that motion of the hip is actually initially pushing that hip down into that posterior position, and then because it is already then put in the taut position, any further than 90 degrees of hip flexion will actually force that humeral head out through the joint capsule instead. Also note that that's actually the extremes for the device. Now remember that these precautions last about 4 months, but they can be longer, so you do need to make sure that you monitor your physician's prescription. Now with regard to adduction, why not adduction? We have the pelvis here. Okay, we have the person's lower extremity here. They're fine with being in a neutral position with their feet equal to their width of their pelvis. That's all right, but it's the motion inward, okay, because that would be a distal motion into a medial and superior direction. Therefore, the head being opposite would be in a medial and superior would be a lateral and inferior. And so again, that's that lateral position that's no longer covered, especially with the gluteus medius being interfered with during the surgery. So that's a potential dislocation. And then with the direction of internal rotation, again, we're actually causing that forceful opposite motion. So you can see that the foot actually is turning. So the hip was going into internal rotation. You see the knee is actually pointing medially. That's where we should be looking. The lower extremity is actually in a fully standing position. So again, we have a medial action. So therefore, we have a lateral action at the hip. And that's, again, where it's been compromised from the surgery. And so each one of these has the potential to dislocate the new hip. And so, again, this is going to be for the posterior lateral approach, and it's going to be for approximately 4 months, and it's related to the soft tissue involvement in the surgery. And that's why it's a totally different restrictions for the anterior approach, because it's totally different soft tissue that was involved. That's the anterior joint capsule. And functionally, with the posterior lateral approach, there are a lot of times where you would probably do these things. Squat down and pick something up, put on your pants, put on your sock, tie your shoe, even just crossing your legs to take a turn to go in a different direction. So that's oftentimes something that's potentially an activity that would happen that someone would actually break these precautions. Turning the lower extremity, maybe that happens while there we go. Okay, turning the lower extremity into internal rotation, that could be when you roll to your side and you're sleeping. So oftentimes patients initially have some sort of abduction pillow. So it's like a little bit of a pyramidal or triangular shaped cushion that's between their legs and strapped to their legs. So they kind of get used to the idea of how to sleep without letting their legs cross, and how to get out of bed without the legs crossing, which is also very challenging. Okay, so again, we're talking about different activities that they're going to be working on. Here's the leg lifters. In this case, it's actually a little bit of a ring or circle that the person's foot goes in, and you see that the person is holding on to that rope or stick, and they're going to use their arm to pull, and then that's going to lift up the lower extremity so they can take it off to the side of the bed. Again, straight leg raises are not allowed at the beginning of this process. Sitting, getting in and out of the chair, it's important that you actually take that lower extremity and place it anterior to the other lower extremity, so that reduces the chance of them actually leaning forward and then doing a closed kinetic chain excess of hip flexion. So before they sit and before they stand, that foot on the injured side will actually be placed anteriorly, and then they stand up by pushing from the from the armrests, or they sit down by reaching to the armrest. Remember, the armrests are what they need to hang on to because that's the most stable portion of the transfer. And then they lower themselves down by and trying to keep that hip from flexing that greater than 90. Okay. Walking, they talk to them about using the walker properly. Remember that when someone's taking steps, that they have to make sure that they're walking. The walker advances with all 4 points advanced on the ground first. Then they take their step, and they step within the boundaries of the 4 pieces of the walker, the 4 points of the walker. Now, if a patient is non-weight bearing, then their foot is elevated off the floor the entire time. It is usually easier for the patient to keep their lower extremity in front of them, so the knee extended and the lower extremity elevated from the floor. That also helps visually to make sure that they're not accidentally touching the foot to the ground. It takes less strength at the knee, but some people may not have enough strength at the hip. Okay. If they're toe touch weight bearing, then again you get to put just the tip. The very tip end of the big toe is allowed to touch the floor. The knee is then flexed, and the ankle's in plantar flexion, the toe is tipped to the floor. And remember that toe touch weight bearing and non-weight bearing are 0% weight. So we should never see a crease in that shoe during toe touch weight bearing, as that would actually break precautions because there is weight then. Here again, we're showing how to get out of bed. You see that in this case, based on the room dynamics, the patient was able to stick their unaffected or the non-surgical leg, lower extremity, over the edge of the bed, which kept them in a nice amount of abduction. And then they're going to use that assist aid to lift their lower extremity, and so that it can come down to the side without them actually ever adducting those lower extremities together. So they should never ever touch those feet and knees together. Okay, and so they're showing again standing up from the bed. That surgical side is actually placed anteriorly, especially if it's a non-weight bearing position. But even not, to protect the precautions for a posterior lateral approach, we're going to make sure that that foot comes out so that they don't flex that knee all the way. Here again, they're giving the description of how to get in and out of the chair. Notice again that surgical side is actually sticking out in front more anteriorly. And again, make sure that they're pushing from the upper extremities on the chair. Okay. Here we go. We have the patient again with the walker. Make sure that the 4 points hit the ground at the same time, and then they actually push through their arms and hop, or push through their arms and load the arms, the amount of weight that's not going through the injured or surgical side of the lower extremity. Occupational therapy will also be addressing additional things using a tub bench. So this is a transfer tub bench, because you'll notice that there's a little bit of an extension of the seat on the outside of the tub right here. And so the person sits on that side, and then what they would do is they would take their non-surgical lower extremity and place that into the tub, and then they would again use that lifter to lift up the lower extremity and bring it into the tub as well. And then using the adaptive equipment such as a shower handle so they can stay in the seated position in a safe process is great. Here what we have is a sock aid. This right here is a sock. It's actually on a little device that looks something like this. It's like a little cup. And dip like this. Okay, and then there's strings on either side. And the sock gets put over the edge of this, and then the person just slips their foot into that little plastic cup, and then it goes into the sock. Okay. Again, the whole purpose of this is to make sure that they're not flexing to the 90 degrees. Okay. Or past the 90 degrees. Long-handled shoehorn, we also have those in our clinic. We have all of these devices except for the shower head. The long-handled shoehorn is just a shoehorn that you stick inside the shoe to pull the back of the shoe back, and then you use the heel. You slide the foot into the shoe, and you use the heel to slide along the shoehorn. Normally they're about, I don't know, like 4 or 5 inches long. The long-handled shoehorn is more like 1.5 feet long, so that you can reach the shoe without, again, flexing forward. They talk about different things to do with moving around. Now, this person is actually using a cane, so they're trying to make sure that they're able to do this, but this is pretty advanced at this point. For the rehab, this is more functional activities. Getting in and out of the car can be challenging. Getting into a car that's got a bucket seat is not okay, so that they would have to fill in the seat. Making sure that they do not squeeze those legs together or internally rotate as they're coming in and or out. Okay, so climbing up into like a truck or an SUV is doesn't have a bucket seat, so that's a safer position for sitting, but challenging to get in and out. Driving wise, patients will not be able to drive if their right lower extremity is involved until they get clearance from their physician. Okay. Okay, so there are some emergency things that are provided for the patients as well. Anything about excess pain. Again, pain should just be getting better over time, not worse. So because their arthritic pain is gone because they've removed that portion of the joint, but they shouldn't have excess pain, which means that something's swelling, something's infected. Anything that's feverish means that there's an infection. Anytime we have something that's in the body that didn't originally belong there, has a chance of having an infectious agent brought in with it, or an infectious agent setting up house on it. And so there's always a possibility. So if their surgical wound is red, hot, smelly, drainage is coming out, that's different besides like an initial couple of days of clear fluid, a fever, all of those things are signs that someone might be having an infection or some sort of problem with that, device. Again, making sure that they're doing their proper dynamics of getting in and out of bed, making sure they're working on their flexibility and their strength. This is a nice, easy thing for them to do. Again, this is for the patients who have posterior lateral approach because we want extension. And so they're just using a folded blanket in the posterior aspect of the femur in order to get a nice stretch of the hip flexors. It would be probably appropriate, instead of having the person just hang out and read, to also do a little ab contraction, because if we don't let the abs contract and then put this in here, we're not really stretching out the hip flexors, we're just making the belly stick out, okay, and hyperextending the back. We really want this tummy tucked, and then there's the actual hip extension or hip flexor stretching. Looking at home safety, lots of things that can trip people up and become actual hazards. And so many times when people have had surgery, they won't have their home care afterwards. And but if someone can't go to the house and actually do an home evaluation to see what would be some safer options for them, having this type of document helps them to figure out things that they might need to address. So we have over here, this is almost like a puzzle. We have the railing, making sure they have one, preferably on both sides. That's not always the case, but sometimes people just have the balusters on one side and nothing on the other, so they might need to put that in there. Things that they need to do is get rid of these throw rugs, because of the fact that they potentially are slip hazards. And again, the balance reactions are in something that's surprising in a large balance challenge would be hip flexion, and they could actually break their precautions. Lots of different things to make sure that, like, there's cords not to fall on. There's a cat over here that could be moving. You'll notice that they put the pillow in the chair because this chair is soft, so it's going to be more like a sling, in which case that would cause that adduction and internal rotation. Just making sure that you have items that you have are secure, so they don't end up falling in front of you and accidentally causing you to flex forward and try to pick something off the floor or do trip over them. So overall, there's just a variety of things to keep track of in the house. Okay. This is talking about recovering at home now. And notice the time frame here, 2 to 6 months. So our 4 months minimally of those precautions, again, for posterior lateral, and then also related to the doctor's protocol. but to really make patients understand that this is, they're going to get their range of motion back, over the course of a year. They're going to get their strength back over the course of the year. So this is going to be a fabulous, fabulous, fabulous change in their body, and they might be able to do quite a few more things than they were in the past because of the fact that the arthritis was making them severely limited, because their range was limited, their pain was limiting them. But it's really what they put into it is what they get out of it, and that's like just about anything in life. So it's important that they do a pretty consistent walking program to work on their walking endurance, which is great for cardiovascular. Consider that these patients haven't been doing that, so their cardiovascular system is probably fairly challenged from the activities that they're doing, and they need to work up on the endurance and aerobic activity as well. Using mirrors and different visual feedbacks in order to be sure that they're doing equal strides and steps on either side. The metronome that you use to keep track of a beat with music like on a piano is a nice training device to make sure that you actually have equal steps, because it takes the same amount of time then. And then eventually making sure that as you'll notice that there are, if there's questions about anything in a home exercise program, it's required that we actually have all of our information in here. So we have all the people that are involved, and then any special instructions. So there were exercises in there, so there's any special instructions regarding those exercises, then that's important that those instructions are very clear, especially the instruction that would say, if any of these exercises or activities are causing you any discomfort, stop the exercises immediately and contact your physical therapist or occupational therapist. So that would actually need to be added to this document. Okay? All right. And so again, this was the document that was provided to the for the student that was at the clinical. This was the document they gave patients for them to have their patient education regarding what's gone on with their hip, what surgical implications there are, what precautions they have, safety things at home, and variety of safety things with their transfers, and how to recover fully from having this great opportunity with this new device. Okay, so that's the end of the hip. Let's go ahead and go into the ankle, and we're just going to kind of watch a little video first to remind us of the ligaments of the ankle.
So as with any hinge joint, you've got ligaments which line either side of the joint, so collateral ligaments, and the joint is fairly weak at the front and the back, but it's got strong ligaments either side. So medially you've got the medial deltoid ligament, and laterally...
Yeah, just a second.
You've got medial deltoid ligament, and laterally you've got 3 separate lateral ligaments. So the lateral ligaments, you've got 2 ligaments connecting the fibula to the talus. So you've got one at the front and one posteriorly, and these are called the talofibular ligaments. So anterior, you've got the anterior talofibular ligament.
Okay, so the anterior, excuse me, the anterior talofibular ligament. This is the ligament that is most often sprained with an inversion sprain of the ankle and foot. Okay, the foot does the inversion, and so the ankle is the actual injured joint, because the foot forced inversion pulls the talus away from the fibula, and the ATFL is the most commonly sprained ligament in the ankle. And when we're looking at special tests, it was the anterior drawer test, where we would take the talus using the calcaneus to push it and move it in an anterior direction, like you're pulling out a drawer anteriorly, and that would actually stress this ligament. And if it was actually torn in any way, first of all, our patients would complain because we're pulling out a torn tissue, but the amount of motion that we see of the foot moving anterior compared to the tibia and compared to the other side is going to tell us whether or not it's a positive test. If it's actually ruptured, there's going to be quite a bit of glide anterior. And so during an anterior drawer test of the ankle, we're testing the anterior talofibular ligament. Its integrity, is it still attached? And depending on how much that anterior motion is of the foot compared to the other side tells us if there's a positive test.
And posteriorly, you've got the posterior talofibular ligament. And then you've got this ligament which connects the medial malleolus inferiorly to the calcaneus. So this ligament is called the calcaneofibular ligament. So those are the three lateral ligaments, and I'll just rotate the model medially so we can take a look at the medial complex of ligaments. So the medial ligaments are called the deltoid ligaments because they're a complex of ligaments which are triangular in shape. And this complex of ligaments consists of 4 separate ligaments. So the triangular shape isn't really shown that well here, but if you imagine that these 4 ligaments that we're looking at here are sort of blended together, and at the apex they attach to the medial malleolus, and they sort of form this kind of triangular shape which attaches to the navicular, calcaneus, and parts of the talus. So it's this triangular shape of ligaments that are blended together. So you've got 4 parts to this ligament. You've got 2 ligaments which attach from the tibia to the talus. So you've got an anterior and posterior tibio-talar part. And then you've got ligaments which attach navicular anteriorly.
So note then that we have an anterior and posterior talus ligament on both sides. Okay, so again, we have an anterior and posterior ligament that attaches to the talus. That's on both sides. So the anterior talofibular ligament, a posterior talofibular ligament, an anterior anterior tibio-talar ligament, and a posterior tibio-talar ligament. So there's, again, the talus is going to have 2 ligaments, an anterior and posterior on each side, one that's 2 for the fibula and 2 for the calcaneus.
And to the calcaneus inferior. So you've got a tibio-navicular part and a tibio-calcaneal part. So I've just switched over to a diagram which shows more clearly the actual triangular shape of this ligament when they're kind of blended together. So it's the medial deltoid ligament consists of 4 parts. And the word deltoid, you might remember it from the shoulder muscle, the deltoid muscle. It basically comes from the Greek delta, which is a triangular symbol. So that's why it's called the deltoid ligament. So that's the ankle joint.
Okay, we're going to keep that.
Okay, so this tutorial is on the ankle joint. So the medial deltoid ligament consists.
Okay, so again, we're looking at this. We have the posterior talotibial ligament. Okay. Now okay, so then we have the talocalcaneal, and then a talonavicular, and then we have the talotibial ligament posterior. Then we have the tibial calcaneal, the tibio-navicular, and then an anterior talotibial ligament. Okay, so again, remember an anterior and posterior that goes to the talus on both, goes on the medial and lateral side for the talus, and then on the medial side, we're going to have one that goes to the calcaneus and the navicular bone as well. And then as a whole, these are considered to be triangular in shape, so it's called the medial side, it's called the deltoid ligament. It is not as common to have an eversion sprain of the ankle. And so it just isn't a functional position that is normally occurring on the body. It is also not the dynamics of the ankle and its triplanar axis. And we have more and stronger muscles on the inversion side that can eccentrically control eversion actions. While on the lateral side, we only have peroneus longus and peroneus tertius that truly are the strength to prevent a inversion sprain. And with an inversion sprain and the foot goes into inversion, there's a lot of body weight that can be distributed in that direction. And so we have less muscle control. We have more likely to be able to go into that motion. We have more motion available. Inversion is already 35 degrees compared to 15 in eversion. And we have very little muscle activity. And in that position, we can load almost the whole body weight through that ankle joint when it's in that inverted foot position. So definitely inversion sprains are quite a bit more common. And again, the most commonly disturbed ligament would be the, right here, the anterior talofibular ligament. Okay. All right, let's go to our notes. Okay, so ligament sprains. For a lateral ligament sprain, the MOI, or mechanism of injury, is inversion. For the medial or deltoid ligament sprains, the mechanism of injury is eversion. Now, the challenge with these diagnoses is, I have to change my screen available to you guys. The challenge with this is the fact that when we're trying to avoid the mechanism of injury, it's obvious that during maximal protective phase, don't do inversion. Moderate protective phase, we're going to do all these other actions, and then we might be bringing in some, strengthening with our everters and such, but maybe more isometrically. And then we get into more of the minimal protective phase, and we're going to actually, reincorporate that mechanism of injury, but not to the extreme. And unfortunately, though, to challenge this, we're going to have to do this in weight-bearing positions because that's what the lower extremity is for. And very easily, with one little slip-up, this person could end up back into that inversion sprain. So you have them standing on one leg, one lower extremity, and maybe they're doing really well. So you have them maybe hold on to 2 fingers with each hand on the parallel bars, and you have them standing on maybe a cushion, and they're not paying attention, and all of a sudden the cushion kind of flattens out on the lateral side, and whoop, they're into that inversion position, and they sprain their ankle again. So it's really important to be very cautious and safety conscious with what activities we're doing, because I may not have ever intended for them to challenge their MOI to that extreme, but accidents happen and the ankle isn't very stable. Remember again that the 3 ligaments on the lateral side attach to the fibula. So if I ask about an inversion sprain, then we're forcing the foot into inversion. The lateral ligaments are trying to check that. If we go to such an extreme that it stretches them, then there'll be stretching ligaments that are attached to the fibula. So it's on the lateral side. We have 3, the anterior and posterior talofibular ligament, and the third one is the calcaneofibular ligament. Again, this is much more common in inversion sprain. A eversion sprain, again, would sprain the medial ligaments. It says there it's about 3 to 5% of sprains usually cause a complete rupture with a fracture of that ligament to its bony connection. So we, with an extreme inversion, we can actually have a bone fracture as well. Medial ligaments, again, in eversion, not as common. We don't have as much range of motion. We have much more powerful medial muscles. It's hard to distribute the body weight in that direction. So it's just less common to have an eversion sprain. It is possible, with, sports or some sort of external force where someone's getting pushed into another person. So it is possible. The four ligaments, remember again, we have an anterior and posterior to the talus, so it's a talotibial. And then we have the other two, one to the navicular bone and one to the calcaneus. So the tibial navicular ligament and the tibial calcaneal ligament are our four. So remember that deltoid is actually referring to its shape, shaped like a triangle, but it is not telling you three-sided. It's saying there's four ligaments that together look like the shape of a triangle. Okay, we already talked about the anterior door test. Again, then it's actually the person is seated with the knee at 90 degrees of flexion. We have slight plantar flexion. So in full plantar flexion, the ankle is locked. So we have to just do slight plantar flexion. We pull the calcaneus anteriorly and we look at the amount of slide anterior of the talus and the foot as compared to the other side. More mobility than the other side is a positive test. And then how much mobility gives us the grades of sprain, grade 1, 2, or 3. Grade 1 is without joint instability. Grade 2 is with joint instability. With joint instability, that's right. And then grade 3 is significant joint instability because that joint ligament is ruptured. Taylor tilt test, basically same position as above, but this time we actually move the person into inversion or eversion, and we look at how much excess mobility they have compared to the other side. If it's more than the other side, it's a positive test. And then again, we look at how much of the excess mobility is there, looking at 0 to 5 millimeters, 5 to 10 millimeters, 10 to 15, or greater than 15. It would be one test that goes to grades 4. More commonly, you see the grade 3 test. So 3 separate grades, grade 1 to 4, not very much mobility. 5 to 9, moderate mobility, and 10 to 15 is significant or severe mobility compared to the other side. So again, if you have excess compared to the other side or the norm, it's a positive test. Then how much more mobility, it tells us what grade it is. And the higher the grade, the worse the situation. The MOI, again, remember to be very careful with the minimal protective phase because we're supposed to be able to incorporate the MOI, but there's a lot of potential for accidentally spraining the ankle again. Special considerations for someone with ankle issues is the fact that we don't have a lot of muscle activity going on at the ankle. We have a lot of ligaments passing it by. We have a lot of tendons passing by, but we don't have a lot of muscle strength support. And so even after a good rehab, they're most likely still going to be wearing some sort of supportive devices at the ankle, especially if they have more challenging activities that they participate, like soccer player or basketball or rugby or jumping activities, places where they, with basketball where they have to land after a jump, and they might not land just right and sprain their ankle. Or in football where you see lots and lots and lots of taping going on because there's forces that would actually push the body into these odd positions as well, like a closed kinetic chain injury. With grade 3, grade 3s are ruptures, potentially with an avulsion. So if there's an avulsion, they will most likely have surgery. But if there's a rupture and they decided not to have the surgery, there is quite a bit of instability or excess mobility at the joint, in which case then they're going to go through a physical therapy program with the idea of trying to strengthen that joint. Again, but that has some limitations to it. And so it's going to be a fairly conservative progression because we have to strengthen before we get into any of that functional activity. Okay. All right, let's go into Achilles tendonitis or tendinosis and rupture. Let's see if I can do a little bit of investigating here. Let's see. I'm just looking up a video, see if we have information on the Achilles tendon. All right, let's see. Let's just take a quick look at these muscle pictures. Okay, so let's look. We have here the picture of the calf musculature. Right here, what we're looking at is, this is the cut portion here and here. The gastroc is missing in this area. Okay, so this is the two heads. This is the lateral head and the medial head of the gastroc, and it would be coming down, gastrocnemius, then attached to the Achilles tendon. Okay, and the key thing, look, if you look, as it's coming down here, it's going to attach to the calcaneus. And notice all the fascial completion that continues down towards the foot, which will then be interacting with the plantar fascia at the plantar surface of the foot. Then we will actually see this very long tendon coming down to then join the Achilles tendon. That's the tendon of the plantaris muscle. It's the third muscle of the triceps surae group. So we have gastrocnemius, the plantaris, and then we actually have the soleus. And notice the soleus is this very shorter but bulging medial and lateral muscle, and it does not cross the knee. It actually inserts just distal to the superior aspect of the tibia. So we have the three components of the triceps surae, and so that is gastrocnemius, plantaris with this extremely long tendon to join the Achilles tendon, and then the soleus. Okay. All right, let's go here. Let's see.
Okay, so this tutorial is on the muscles of the leg. So the leg is this region of the lower limb which lies between the knee joint and the ankle. Okay, so this tutorial is on the muscles of the leg. So the leg is this region of the lower limb which lies between the knee joint and the ankle joint. So I'm going to break this tutorial into two parts. So I'm going to do the first part on the posterior compartment, and then the second part will be on the muscles of the anterior and lateral compartments. So just like my tutorials on the thigh and the upper limb, the muscles of the leg can be broken down into compartments, and these compartments are separated by intermuscular septa and the interosseous membrane between the tibia and the fibula. So the muscles of the posterior compartment here mainly act to plantarflex the foot, flex the digits, and invert the foot. So plantarflexion is when you get up on your tiptoes, basically. So if you can see this angle between the foot and the shin, you extend this angle. So you open this angle up further. So you get up, it's getting up on your tiptoes essentially, and dorsiflexion is bringing your toes towards your head. So if you imagine lying down on your back and bringing your toes up towards your head, that's dorsiflexion, and plantarflexion is the opposite. So the muscles of the posterior compartment plantarflex the ankle joint, they flex the digits, and they invert the foot. The muscles of the anterior compartment here do the opposite really. So they dorsiflex the foot, so bring the toes upwards. They extend the digits, and they invert the foot also. So as well as plantarflexion of the leg, it results in foot drop. So it's worth making a note of that point. So that's the common fibular nerve, which winds around laterally around the neck of the fibula, and it's quite exposed in this region. Okay, so now I'll just run you through the muscles of the posterior compartment, and I'll talk about the origin, insertion, and the actions. I'll just get rid of the nerves. and we can focus on the muscles now. Okay, so the muscles of the posterior compartment can be separated into superficial and deep muscles, and in total you've got 7 muscles. So you've got 3 muscles in the superficial layer and 4 muscles in the deep layer. So I'll just work from superficial to deep and talk you through these structures. So obviously we're looking at the most superficial muscle here, and this is called the gastrocnemius muscle. So this muscle has 2 heads. It's got a medial head here and a lateral head. And this muscle inserts onto the femur on the medial and lateral condyles. So the medial head inserts onto the medial condyle and the lateral head inserts onto the lateral condyle. So I'll just show you that in a bit more detail. So I've just isolated this muscle so you can see it a bit more clearly. And you can see the origin of this muscle on the upper surfaces of the femoral condyles. So the medial head originates on the upper surface of the medial femoral condyle, and the lateral head originates on the upper surface of the lateral femoral condyle on a distinct facet. So you can see on this side there's a facet here which the lateral head of the gastrocnemius muscle originates on. And if we follow the muscle down, it's not quite shown clearly here, but it inserts onto the calcaneus via the calcaneal tendon. So I've just brought the muscles back in, and you can see this tendon now. So this is also known as the Achilles tendon.
Okay, so looking at the Achilles tendon right here, what tends to be the limitation is the gastrocnemius and soleus are pretty powerful muscles, with the gastrocnemius being a type 2B muscle, so it's a fast glycolytic muscle. It is a power muscle, so it has a lot of strength but not a lot of endurance. Our soleus is more of a type 1, so it is a postural muscle. It's a red oxidative muscle. And so when we get in a situation where there is a quick force or repetitively quick force to the tendon, only one of the muscles is really meant to be able to provide protection against that. So a tendinosis or a tendinitis for the Achilles tendon is going to be some sort of inflammation along the bony component to where the Achilles tendon is attached to the calcaneus, or at the musculotendinous junction, where we actually see the blend of that pinkish, reddish color, brownish color of the muscle blending into the white of the tendon. So that's where we would actually get some inflammation, because remember that tendons don't have a lot of blood. The blood that they get is from the muscle or from the bone. So in that area we might see some tendinitis, but within the tendon itself, that would be that abnormal condition of the tendon, so that's the tendinosis. So we could have a wear and tear situation, maybe related to the fact that the patient is maybe somebody who pronates. And if they pronate, then that medial portion of the Achilles tendon is constantly getting overstretched and overstretched, overstretched as compared to the lateral side. So we can have a wear and tear in that area, in which case we'd have swelling down by the bone or swelling at the the musculotendinous junction, or a scarring process happening in the tendon directly. A wear and tear to that area might make that Achilles tendon weak over time, in which case what seems like a minor event can actually cause this to rupture. And basically what it is a full body, very quick, let's say, forced dorsiflexion. So stepping up onto a curb, missed stepping the full foot onto the curb, only the forefoot made it onto the curb, and then you step up in order to elevate yourself to the next level of that curb. Thinking that the foot was securely placed on the curb on the upper surface, you actively and pretty assertively step up, not realizing the foot was not supported, when the body weight gets transferred to the lower extremity that's being placed on the curb, it spontaneously drops the heel because it wasn't ready, and before that the gastroc and soleus can actually control that, there's a quick stretch to that tendon with full body weight stretch. So not like quick stretch like PNF where we do this gentle little teeny tiny end range stretch. This is a full body weight stretch, and then the muscle tries to contract to save itself and to adjust the body position. So we have the body weight going downward, the contraction force going upward superiorly towards the knee, and those two forces working against each other end up causing the rupture to the Achilles tendon. Okay, so let's go back to your notes. And so we start off with Achilles tendonitis or osis. What this signs and symptoms are is localized pain at the mid portion or the distal 1/3 or the insertion at the calcaneus. So depending on the person's activity level and depending on the person's anatomical design of their gastroc, we have a specific pain area in the mid portion of the muscle, the distal 1/3 of the muscle, or the insertion of the calcaneus. Again, because of that, the features of the gastroc or the features of the tendon muscle and potentially the dynamics of the person's body alignment, these are intrinsic factors that increase the odds of having problems with the Achilles tendon. So again, the low vascularity, as we age, the flexibility of that tissue is less. Over time wear and tear, tendon degeneration, poor flexibility, or anatomical alignment. For some patients, you might see that the calcaneus is actually in a valgus position, in which case that puts stress on the medial aspect of the Achilles tendon, or the calcaneus at the subtalar joint is in the varus position, which places more stress on the on the lateral portion of the Achilles tendon, in which case then those are intrinsic features that make it increase the likelihood of something happening with this tendon. And then we have extrinsic features that are environmentally caused. So bad training, maybe always stretching, but stretching only the medial side because the person is pronating, so they're not paying attention to how they're overstretching one side and not stretching the other. Running surfaces for people who run on the road. Remember that the roads are actually domed with the highest level in the center of the road, and so the drainage will go towards either side of the curb to get to the sewer system. Well, that would mean that when the person's running on one side of the road, if they're running so that the curb is to their right, okay, then the right foot is actually in an inverted position, and the left foot is actually in an everted position. So on the right side, the lateral Achilles tendon is getting stretched every single step excessively, and on the left side, the medial side of the Achilles tendon is getting stretched excessively. Okay, so that's why it's important for runners to sometimes run with the direction of traffic, sometimes run with the opposite direction of traffic, with regard to foot alignment being equal over time. Footwear, there's very specific footwear for people. Most people do not wear proper footwear for the design of their foot. People tend to be more pronators or supinators. People with pronators have pes planus or flatter feet, and people who are supinators have pes cavus, so they have more arch in their foot. And the shoe wearer needs to appropriately accommodate those structures and support them, otherwise we get wear and tear in this tendon. Okay, so rehab considerations for someone who has the inflammatory process or the scarring process is to conservatively use therapy, okay, because we really need to be careful not to turn this into a rupture, okay. So max phase, what a shocker, you're supposed to be using impairment relieving devices. So modalities, ice massage is great because it's in a nice local area, so we get the cool effect and the massage effect at the same time. Ultrasound is possible. Again, we're If you're talking about the bone or the muscle end of the tendon, then we're going to use non-thermal because we have an inflammatory process. Within the tendon, we don't have blood supply very good, so we're again going to use the non-thermal effect. So it's best to use non-thermal on these tendinitis, tendinosis conditions. If there is any type of edema, which is possible that they're also wear and tear at their ankle as well from this process, and the ankles do swell, we want to decrease their edema. And we also want to decrease the effects of the MOI, so we would not do the activities that cause this wear and tear on this tendon during those first phases. And technically, we would retrain our patients on how to do the activities without experiencing the MOI. So our runner, talking about the position of their feet on the road, talking about the proper shoes so that they don't get into that situation. Sometimes patients will actually use a heel lift inside their shoe. That places them effectively in a plantar flex position. And so they actually reduce the stretch on the Achilles tendon to give it some relaxation during that time. You just need to be careful because extended use of that would actually cause it to be tighter now in that plantar flexion position. Over time, we're going to gradually increase their range of motion, increase their strength. Lastly, adding eccentric controls because that's usually the mitigating factor in most injuries are eccentric muscle activity. And then function, again, are they runners, are they jumpers, are they basketball players, are they just walkers? What are they doing all day with that ankle and foot? It will take some time, though, to do some investigation posturally to find out what was going on with that ankle and maybe address some other postural deviations that are leading towards this problem. Okay, Achilles rupture, though, again, now, most likely there was some sort of wear and tear a little bit over time. And then there's that moment in time where there's a quick stretch into dorsiflexion in a weight-bearing position, full body weight, stretches out that Achilles. The gastric and soleus try to contract to accommodate that. Muscles pulling superior, body weight going inferior, and snap. Usually snaps about 3 to 4 centimeters proximal to the calcaneal insertion. You'd be able to palpate an actual gap in that area where the Achilles tendon has ruptured. It's pretty powerful muscle, so when the tendon goes, it kind of blows up into what looks like angel hair pasta. It makes it very challenging to surgically reattach that tendon. During surgery, they will actually open up the posterior distal calf, and they will use pretty much a large wire, kind of like a wire hanger, to grasp that gastroc and soleus and pull it back inferiorly because it's such a strong muscle, it recoils, and it has to be pulled down very fast in surgery right away. Otherwise, it can get stuck up there and adhere. Basically take a wire hanger in a loop, an open loop, so that the loop is actually superior, and then they twist the hanger to attach it to the distal portion that's still attached, and then they'll use smaller sutures to actually sew together what other tissue they can find and to be able to attach. That little loop that's designed will actually be sticking out of the calf and out of their cast. The patient will be casted. They will be casted into a plantar flex position, and over a course of time, eventually the physician will pull that wire straight out of the cast and out of the person's body, and then they'll continue with the cast for a period of time to allow the additional sutures to heal and absorb, and then eventually the cast will be removed, and the patient will be on some great restrictions for plantar flexion. So they must remain in plantar flexion in all activities for a very long time. Remember, the mechanism of injury was a forced dorsiflexion, so dorsiflexion is the mechanism of injury. Dorsiflexion is going to be avoided until the minimal protective phase, basically. Thompson test was the special test to find out if the Achilles tendon was ruptured. So the patient was prone, the foot is free over the edge of the table, squeezing the calf if the foot plantar flexes, then the tendon's intact. If the ankle does not plantar flex, then the Achilles tendon is ruptured. So if you squeeze the calf and there's no plantar flexion at the ankle, it's a positive test for an Achilles tendon rupture. what should someone do? Basically, for rehab purposes, it says non-surgically, if the patient had a small tear in the Achilles, and they have like a more of like the tendonitis kind of thing, or just small injury, so that they don't want to do the surgery. For a negative outcome, a small injury will become a full rupture in about 8 to 39% of people. And without that repair from that small injury, they already have decreased strength, endurance, and power. As such, it will take less to cause it to rupture again. If they have this surgical repair, the negative outcome of a re-rupture is 0 to 5%. So they are better off functionally, especially with that muscle power, to have a surgical repair than not. Okay, but that tells me that if someone has an injury to the Achilles tendon, and it's not just an inflammation, but they believe there's a tear, the odds of them actually rupturing and completing the job is actually fairly high, and I need to be cautious of that in therapy. After the surgical repair and rehab is done, there's very little extra chance of having it re-rupture. So they're kind of like the rest of the people out there that's never had a rupture of the Achilles tendon. And in fact, they've actually increased the overall strength characteristics of that muscle through that operative repair. Non-operative, basically for rehab, we're going to monitor the healing phases of the tendon with great appreciation of the power of the gastrocnemius soleus, weight-bearing and ankle stresses with spontaneous movements such as eccentric dorsiflexion. So what that's saying is tendons heal very slowly. They don't have great blood supply. And so this is going non-operative treatment for someone with a tear in their Achilles is going to be fairly conservative in order to make sure it doesn't rupture. Okay, that's the end of ankle foot diagnoses. Okay. Let me just see if there's anything else I'd like you to appreciate. No. I want to go to, I want to talk about plantar fasciitis. Let's do ligaments again. And here we go. Let's get this to go to the ankle ligaments, and we'll talk about the fascia of the foot, the plantar fasciitis, which is right there, foot fascia.
Okay, this is a tutorial on the fascia and retinacula of the foot. So we're looking here at an inferior view of the foot. So this is the plantar surface of the foot. So I've removed away the skin layer, and this here is the plantar aponeurosis. So this is similar to the palmar aponeurosis that we have in the hand. So posteriorly here, we can see the attachment of this plantar aponeurosis on the calcaneus. So it actually attaches to the medial process of the calcaneal tuberosity. And then it extends forward and expands along the digit. So it forms these longitudinal bands of fibers.
Okay, so remember that this fascia is one of the structures most superficially that is supporting the arches of the foot. And then previously I showed you a diagram that in order to appreciate that as the Achilles tendon was running inferiorly to the calcaneus, that you saw a blend of that into the fascia that is supporting the posterior medial and lateral aspects of the calcaneus and then running inferior into the plantar surface. So people who have extremely tight gastroc soleus that pull on the Achilles tendon, pull on the calcaneus, pull on the fascia around the calcaneus, therefore pull on the plantar fascia and actually cause the arch to collapse. So it's not uncommon for patients who have tight calf muscles to have very flat feet. Now, when we talk about stretching the gastroc and soleus, we've talked about, patients in a supine position, you're going to actually grasp the calcaneus, pull the calcaneus inferiorly first, then have the foot supported by your forearm and use your body weight to actually dorsiflex the ankle. And it is that it's really important pull on that calcaneus inferiorly that prevents us as therapists from flattening out the arches, because instead of the gastroc soleus stretching, we ended up stretching out the plantar fascia, which will give way before the gastroc and soleus because they are so powerful.
And it's not shown on this model here, but just distal to the metatarsophalangeal joint, you've got some connections, horizontal connections between these longitudinal bands. So these horizontal connections form the superficial transverse metatarsal ligament, and you can see the deep ligament, which...
Okay, so then inside the plantar fascia, for plantar fasciitis, we have inflammatory processes that are potentially involved here. But remember, because it's fascia, it kind of has the rules of what goes on with ligaments. So down here, posterior on the foot, near the calcaneus, again, the bone is supplying blood supply. So we're going to see inflammatory cells and inflammatory processes here, so much so that this pull on this bone will actually cause bone spurs that develop right in the inferior aspect of the calcaneus, and they're extremely painful as they're pretty much spikes in the they're pretty much spikes inside the foot that the person's standing on. And the spike from the bone is actually getting pressed between that spike, then the plantar fascia, then the skin, and on the fat pad at the bottom of the foot, and that's all of those things are getting compressed between that spike and the ground. And so obviously that is really uncomfortable. And then again, it's somewhat of a misnomer for within the foot, plantar fasciitis actually doesn't have blood supply in this area, so we're going to have little microscopic tearing and such, and scarring. Lots of different research on things to do in this area. Ultrasound has definitely been one of those things that's been effective. But again, we're talking about a non-blood supply type of situation in the middle of the foot, and then an over-inflammatory process inside the calcaneal area. So non-thermal ultrasound is generally the way to go. Electrical stim for TINS is also pretty commonly used. And probably most importantly has been success with kinesiotaping in order to support the arch, support the fascia so it does not have to be on stretch all the time, and then again go back to that gastroc soleus and stretch that out. So recovery-wise for plantar fasciitis, max protective phase, get rid of those inflammatory impairments, pain, edema. Get rid of, try to gain some range of motion in the moderate protective phase, patient education in the maximal protective phase, but continuing throughout the process as you add more functional activities. Lots of people that spend time on their feet a lot, so not just runners, but people that are walking all the time, healthcare workers, teachers, people that stand on their feet industrial-wise. They may need education on shoes, so that education will go throughout the therapy for sure, because as I add more functional activities, I need to, again, go back and educate on the proper shoe device, proper standing, proper exercises, etc. So lots of different opportunities for recovery for plantar fasciitis, but a fairly pretty intense pain that comes from this area, again, because it's basically standing on a spike that's within the foot and crushing tissue between that spike and the floor. Okay, so that was going to end our lecture for the review of the hip replacement home exercise program and precautions and functional activities, and then the diagnoses for the ankle and foot.